Thank you, Jonathan. It's a real pleasure to be here. Stanford was my medical school. Paul Berg was my molecular biology teacher, so this is a special day for me. Title of my talk is Diagnosis, the Beauty and the Beast. And to watch LT diagnose a case like that, to me, is the beauty of diagnosis. It's amazing to see how the pieces fall into place, all the things that are going back and forth in his mind, really quite amazing. I'm here representing our nonprofit, the Society to Improve Diagnosis in Medicine. Is anybody a member? Okay, I see 5 hands, and you have my permission to multitask. So if you're interested in diagnosis, this is the place for you. We are all about diagnosis and how to improve it. Our vision is a world where no patients are harmed by diagnostic error. We believe diagnosis should be accurate, timely, efficient, and safe. It's important. It's really important. It's important to our patients. If you survey them, their number one worry that they'll be misdiagnosed. It's important to us as physicians, the most critical of a physician's skills, every doctor's measure of his abilities, most important ingredient in our professional self-image. So important. It's half of medicine. But it's interesting. We just kind of take it for granted. We don't talk about it very much. We don't measure it. What do we really know about diagnosis? Well, one thing is we know it is hard. There is uncertainty at every step of the process, and our processes are so complicated. The complexity involves our patients, our doctors, our healthcare systems, and depending on how you count, there are over 10,000 diseases. It's amazing that somebody like LT can come up here and in 15 minutes diagnose a case as complicated as the one we just heard. But we also know that diagnosis is getting better all the time. And it's thanks to tests. The tests are getting better and better. So in the 1960s, anybody have one of these under their tongue? Yeah, we all did. And now, forget it. A little thing scans across your forehead, we know your temperature. How about how we diagnose appendicitis? When I was in medical school, we had the history and physical exam. It was pretty good. We got the diagnosis right 80% of the time, but we sent 17 patients to surgery unnecessarily. And now we have a CAT scan, and the sensitivity is up to 94%, and only 9 patients are going to surgery unnecessarily. We've cut that in half. If you think about what tests we had in the 60s, we had some simple things in the lab. Radionuclide scans were just coming out. And if you go to the lab now, or if you go to your radiology department, it is unbelievable. The armamentarium of tests that are available to us are just breathtaking. And if you read Eric's columns or follow his blogs, there's not a month that goes by that some amazing new tests becomes available to us. We can diagnose congenital conditions by facial recognition software. We can test for Parkinson's from AI that listens to your voice. We have the AliveCor EKG device that fits on your iPhone. We have a non-invasive device that can diagnose a subdural hematoma just by holding it up against your skull. And we have last year's winner of the Qualcomm X Prize, the Tricorder X Prize. DXR plugs into your cell phone and can tell you 5 of your vital signs and can diagnose or exclude 9 different clinical conditions. So this is the beauty of diagnosis, watching LT diagnose a case, seeing how it improves. It's the most challenging cognitive task that humans face, in my opinion, but we're getting better at it and we do it really well. So we're not here to beat up on doctors at all. In my opinion, it is amazing that we do as well as we do with all the complexity, all the uncertainty, and all the 10,000 diseases that are out there. We get it right 90% of the time, or something thereabout. And that gets us to the dark side. What is that other 10%? What are we going to do about all those cases of diagnostic error? So quick question for you. Hold up your hand if you would say that your doctor is as good as LT. I got maybe one. It probably is LT, right? Yeah. Yeah, well, my doctor is not. I wouldn't be holding up my hand. Okay, take off your professional hat. You're not a doctor. You're not an AI scientist. Think of yourself as a person, a family member. Has one of these three things befallen you or a member of your family? Somebody was given a diagnosis that was just completely wrong, or they were given the right diagnosis, but it should have been made much earlier, or somebody is still suffering with symptoms that have been presented for diagnosis, but there is no diagnosis yet. Anybody meet one of those conditions? Yeah, it's over half the room. Well, this is the problem of diagnostic error. This is what we know about the incidence of diagnostic error from different kinds of research studies. You've heard about some of these data already. Some from malpractice claims, we know it is the number one reason for a malpractice claim is a diagnostic error. The most credible data, in my opinion, comes from studies that use standardized patients. So these are secret shoppers sent out into practices, and they're meant to portray patients who have classical conditions, chronic obstructive lung disease, rheumatoid arthritis, and we do pretty well. We get it right 87% of the time. We get it wrong 13% of the time. Chart reviews. Going back and looking through the medical record to see how we're doing. Our colleague, Hardeep Singh, looked at primary care patients, found that 1 in 20 patients in primary care will have a diagnostic error every year. Every year. If you live to be 60 or 70 or 80, you multiply those odds out, odds are very high that it will befall you. And the gold standard are autopsies. We know from autopsy studies that even in this day and age, even with all the deluxe lab and imaging studies that we have, there are major discrepancies, 10, 20, 30% of the times. These are the research studies. What does this translate to in actual practice? And that's where it gets tough. I don't know my own rate of diagnostic error. I don't know yours. There isn't a healthcare organization in the country that is measuring the rate of diagnostic error. This is just what we think it would be. So in radiology, pathology, the visual medical specialties, 2, 3, 4%. Primary care, probably 10%. Medical specialty care, we really don't know. Very little data in that domain. So these are very common problems. This is what it adds up to. An estimated 40 to 80,000 deaths a year in the United States. So I'd like you to look at that number for just a minute. 40 to 80,000 deaths a year would put it in the top 10 causes of death. If you add up deaths from breast cancer and AIDS and gunshot wounds, you're kind of getting there. Very big problem. And if you divide it by the number of hospitals in our country, it means that in every hospital, 10 deaths a year from diagnostic error, patients being harmed every day in our clinics, our emergency rooms, and on our wards. This was the conclusion from the National Academy of Medicine, who studied the problem. It is likely that most of us will experience at least one diagnostic error in our lifetime, sometimes with devastating consequences. So what do we know about diagnostic errors? We know they're common. They occur in every setting where diagnoses are being made, and they arise from the complexity of the diagnostic process and shortcomings, breakdowns in how we think and in our healthcare systems. So let's get into that a little bit. Why do these happen? Who knows who this is? Anybody recognize this person? Larry? Yeah? This is Thomas Eric Duncan, the first patient diagnosed with Ebola infection in the United States. He was diagnosed in the summer of 2014 when there was an Ebola epidemic in West Africa. It was all over the news. The CDC sent out announcements to every emergency room, watch out. He came into an emergency room in Texas with complaints of being dizzy, nauseated. He had a headache. He had a fever. Temperature was 103. The nurse, the triage nurse who interviewed him, got this history of he had recently returned from West Africa, put that in her note, but when the physician talked to him, he didn't get that travel history, didn't talk to the nurse, didn't read the nurse's note, and ended up making a diagnosis of sinusitis, sent him home. Came back 2 days later when he was correctly diagnosed, and in the meantime, in that period, had exposed a dozen other people to Ebola infection. So this is a case of diagnostic error. It would have been great if the diagnosis had been made on that first ER visit. It wasn't. Why? Why was the diagnosis missed? There's a famous paper by George Bordage. Why did I miss the diagnosis? What do you think the answer was? I just didn't think of it. And that is so often the case. So when we think about diagnostic error, this is the approach I use. Here's the sharp end of medicine. Here's Mark in the emergency room seeing this patient. Mark, why didn't you think of Ebola? And it gets at the cognitive causes of diagnostic error. But the Institute of Medicine would remind us to spend more time thinking about the blunt end, our healthcare systems. What's wrong with our healthcare systems? What can we fix in that domain? Because if you can fix something in the system end of things, you've made the world a safer place. What are the common causes, cognitive and system related? Well, here they are. The most common cognitive breakdown. Sometimes we've never heard of the disease. That wasn't the case here. Everybody knew about Ebola. Sometimes we have problems collecting the data. We don't do the physical exam right. We miss something in the lab results. But the huge chunk of the pie is putting it together, the clinical reasoning step. I just didn't think of it. And how about our system-related problems? Well, if you work in healthcare, you know all about these. You run into system problems every week. They are things that annoy you, that you wish you could fix. Breakdowns in communication and coordinating care. Trouble getting an appointment. Trouble talking to the consultant. Trouble talking to the radiologist. The culture isn't quite right to support the work that we do. And the thing at the bottom is a really mouthful, the normalization of deviance. That's one thing we've learned a lot about. It means you just get used to things the way they are, even though they aren't ideal. This was a problem in my own medical center. We had no radiologist on nights or weekends. So if you came in with chest pain, your chest x-ray was read by a moonlighting endocrinology fellow. And on Monday, the real radiologist would come in and say, hey, you missed that pneumothorax. It was normalization of deviance. We knew we couldn't afford the radiologist. We just never said anything about it. Hey, what is the mountain goat doing up there in the cloud bank? So if you study diagnostic errors or if you study safety breakdowns in any industry, you find these events called context errors. The pilot thinks they're at 10,000 feet, but they're really at 1,000 feet, about to crash into the mountain. They think there's no ice on the wings, but there is. They think they have enough gas to get back to the airport, and they don't. They think the patient has sinusitis because they've got headache and a fever. But that's not even close to what was going on, a context error. They were in the wrong context. A colleague of ours, Pat Crosscarry, has a paper, Context is Everything in Diagnosis. Context is everything. And if you're not in the right context, you do not have a chance of making the correct diagnosis. Anybody have a dog? Any dog people? Yeah, quite a few. I'm guessing you did not go look at 5 litters to pick out your dog. That's not how we are as humans. We go see one litter or we go to the shelter and we fall in love with a dog, a puppy, and it's it. We fall in love with that first puppy. It's called satisficing. Herbert Simon got the Nobel Prize for this concept in the field of economics. This is how we are as human beings. It's the opposite of optimizing. So instead of making a differential diagnosis, instead of looking at a list of those 10 causes like we just saw, we're happy with the first thing that seems to explain the facts in front of us. We're happy with the diagnosis of sinusitis. We don't think about what else it could be. We satisfice instead of optimize. It's that system 1 process that Eric alerted us to. So now that we know how doctors think and how these errors arise, how did this Ebola diagnostic error occur? Well, data collection was not great. There was a key historical fact that was missed. He was in the wrong context, the physician who saw the patient. There was premature closure. There was no differential diagnosis listed in that patient's medical record. And how about the system-related factors? Decision support. Where was decision support in this case? Would it have helped them consider the possibility of Ebola infection? And how about teamwork? The number 1 recommendation in that report from the National Academy on improving diagnosis was to work in teams. And in this case, the nurse was not an effective part of that diagnostic team. Electronic siloing. This is another problem with our EMR. The nurse is writing her note, the physician is doing his thing, and never the twain shall meet. One of the beauties of that National Academy report is that it described diagnosis as a process. You move through it. You present for care. The physician or the diagnostician interviews you, does a physical exam, starts to come up with hypotheses, makes a diagnosis, and hopefully there's learning built in. So if there's right or if you're wrong, you learn from that process and can progressively improve it. This is data from Gordy Schiff, who looked at 583 cases of diagnostic error and mapped where in the diagnostic process there were breakdowns. And there was not a single step where we did well. There are breakdowns at every single step of the diagnostic process. The biggest error rates were encountered in coming up with the diagnosis and generating those hypotheses, in ordering the right test, and looking at those tests and following up on what they suggested. Breakdowns everywhere. So let's talk about how we can improve diagnosis through AI and health IT. And I don't really care how you do it, but I'd like to show you my wish list of the problems that we need solved. So what can you do to help improve this diagnostic process? Can you improve access to care? For example, how do I get to LT so he's my diagnostician instead of the doctor I now have? And it's not really a joke. If you think about access to care, it's not only a problem in the United States, but if you look around the world, the vast majority of people do not have access to a physician at all, let alone a physician of outstanding diagnostic capabilities. So improving access to care is the number one problem that I would like to present. But there's many other ways that you could help us. Improve patient engagement in the diagnostic process. How could we get the patient's history so it's all right there in front of us? Improve communication so that we can talk to each other in real time, so that we can communicate with the radiologists and the laboratory professionals and the consultants who could help us solve the puzzle. Even with the history and physical, we could use help. We know all about big data in medicine. When I was at the VA hospital here seeing a patient, here comes 15 inches worth of medical records that we need to go through. Help us with that. Organize that data. Make it easier for me to see the time frame of disease, the time course of what happened, all the facts that might be relevant. Diagnostic testing is error prone. Help me order the very best tests for the problem that I face. Make sure I'm aware of all the test results that exist. We have data from Hardeep Singh again that about 10% of critical test results that are sent back to physicians are never followed up upon. 10% of critical test results. Show us data in graphs, in relevant clusters, in timelines, so we can see those trends and act upon them. Help us with clinical reasoning. This is the most error-prone part of the process. Help us with that. Make sure the problem list is accurate. Studies have been done looking at the problem list. It's virtually useless. 80% of the data in problem lists today is inaccurate, not up to date, misleading. And help us improve that learning cycle, which in many places almost doesn't exist. Help us identify who's at risk for a diagnostic error. There's an elegant system that's being used at Kaiser Permanente, the SureNet system, that identifies patients who have a super high PSA but haven't seen the urologist, who have blood in their stool but haven't had their colonoscopy. It's done with machine learning, a little help from AI. We need those kinds of tools. It allows us to detect errors before there's harm. Help us with the feedback cycle. You know, we mentioned that the autopsy was the gold standard. Autopsies have virtually disappeared from medicine today. And there was nothing more powerful than seeing your own patient on the autopsy table and seeing that you made a mistake. That's gone. What's replaced that? Nothing. So we don't get that powerful feedback that we once had. We need ways to get more feedback to combat the overconfidence that is just ubiquitous. Help me monitor my own performance. Am I as good today as I was yesterday? Am I as good today as I was 10 years ago? How am I relative to my peers? Help monitor our systems. How good are we at Stanford compared to some other hospital? There should be ways to do this. Help us do these things. We mentioned how nice it would be to have help with the clinical reasoning part, help with differential diagnosis. So here's an example. This is a decision support tool You'll see some different really elegant tools from Art Papier in just a minute. But Isabel is a tool to help with differential diagnosis. You put in the key findings in the case. It gives you some things to think about. So here's the key findings in that case we just saw: fever, abdominal pain, headache. And we put in the travel history of West Africa. So here's the differential diagnosis, things to think about over on the right. Ebola hemorrhagic fever, the number one problem. Was this available to this physician? Is it available here? How many people know if Isabel is available to Stanford physicians? Don't know. Or DXplain, or Visual DX, or any of the other decision support products that can be so helpful in combating diagnostic error. This is a study that was done of Isabel. It was done in a teaching hospital, pediatric ICU, and left to their own devices. The residents got it right 89.4% of the time. With Isabel, it's up to 92.5%. And you can look at that and you can say, that's not much of a difference. Is that statistically significant? But if you're a parent or if you're a patient safety person, you look at that and you say, well, without Isabel, there's 10 kids at risk for harm from diagnostic error. And with Isabel, it's down to 7 or 8. And I would propose to you, this is exactly where we are in medicine today. We get it right 90% of the time. How are we going to get to 92% or 95%? You have to help us get there. We need tools that will help us get to those higher numbers. This is the mandate we have from the National Academy. Improving the diagnostic process is not only possible, it represents a moral, a professional, and a public health imperative. So absolutely, think about what you can do in your own world to help us attack this very major problem. And last but not least, if you're interested in diagnosis and in diagnostic error, please think about joining our society. Come see us at our annual meeting, which will be in New Orleans this fall. Thank you very much.
You had a great comment on the normalization of deviance. A lot of things are imperfect, but you know what? It's like car crashes, right? You can't not have car crashes if we're going to drive cars. Maybe we just can't have medicine if we don't make some diagnostic errors. Versus you look at airplane crashes, we find that unacceptable headline news. Why is that different? And can it be different in medicine?
Yeah, that's a fascinating question. I guess it's wonderful that patients trust us as much as they do. Patients trust their physicians, and they trust that we're smart and we'll help them and we'll diagnose their problems. And the challenge for us is to earn that confidence. And, you know, in all honesty, we are not perfect. And we're not even that close to perfect. I'm not sure 90% is an acceptable place to be. Mm-hmm. So absolutely, that's the tension that faces us all. You know, we're not perfect. We're nowhere near the levels of excellence that are achieved in aviation. But we need to start thinking like they do. We need to start analyzing near misses and learn whenever we can, a process which is virtually missing in medicine today, so that we can improve.
Very good. Just to answer one of your questions about, the DXplain, Isabel Visual Diagnosis, those are available at Stanford and the VA and many other places, but very rarely used. Why do you think that is?
Yeah, thanks. So Dean Sittig has a paper that looked at decision support. He asked doctors, are you aware that your hospital has these tools? Yes. Are you aware that they're terrific and they'll help you? Yes. Do you use them? No. Why not? Well, I'm behind schedule 80% of the time. So I don't have time. But I'm not sure that's the real answer. I think the answer is overconfidence. I think people believe they're doing a good job, and by and large, they are. They're happy with that 90%. And because we don't get feedback, because we don't see our errors, we don't get autopsies, if a patient is injured from a diagnostic error that I made, what do you think the chances are that patient will come back and see me? Then it's not going to happen. They'll find another doctor, another healthcare system.
What's the chance they'll come back and sue you?
Well, that's actually very low.
Yeah.
But it's overconfidence, and I don't have enough time. Some combination of those two things.
Got it. Question from Anna Witt. Dr. Graber, how do you get doctors on board with the idea of providing feedback on clinical performance? Do we really want to be compared to other doctors or other hospitals? Maybe I don't want to know, because how is that ever going to help me but just get me in trouble?
I think every physician has great pride in their capabilities and would love to be better. And the way you get better is by feedback. That's how expertise develops. You get feedback. And right now, the culture in medicine is not favorable for that. If I discover a diagnostic error, or if Jonathan discovers one of mine, it's a tough conversation. But the answer is to give permission. So if I told Jonathan, if you find one of my diagnostic errors, could you please let me know? Mm-hmm. I'd like follow-up on the patients that I've seen. So if you find something out that would be influential to me, please tell me. So if we have those conversations, we would get better feedback.
I'm just tying back to your kind of autopsy comment. I think it was 50 years ago, basically half of all deaths or hospital deaths resulted in autopsy. Now it's something like 2%. I don't know if you know why that changed. Why do we not care anymore? Or what? Maybe we don't think we have anything to learn?
Well, as in many things, the answer is money. Yeah. Autopsies used to be paid for, and now they are not. So unless you pay for it out of pocket, there is no autopsy. But there are places in the country, and there are other countries where autopsies are still done very commonly. And they still show those very high rates of major disagreement. And it's not esoteric things. It's not patent foramen ovale. It's cancer, it's infections, it's cardiovascular diseases, it's pulmonary emboli. It's the everyday bread and butter things that we are still missing for some reason.
I was thinking often, I think about a challenge within diagnosis like the Ebola case. It's like, yeah, it could be Ebola or it could be sinusitis. And you know what, if I guessed sinusitis every time, I would be right way more than I'd be wrong. We go for the usual thing because we're usually right. How do you even make someone think about the rare conditions? And is it pay off? Is it fruitful to do so when you'll most of the time be wrong if you chase that avenue?
Yeah. Thank you, Jonathan. Well, that's the needle in the haystack problem. But every physician plays that game every time you see a patient. Is it sinusitis or is it something more serious? Is it Ebola? Mm-hmm. If you don't think of it, you have no chance of making the diagnosis. Mm-hmm. And what we're advocating is to try and break out of that System 1 intuitive process that doctors use. You recognize things and you move on to the next patient. Our advice is stop and think. What else could this be? When you go to medical school, we all learn to make the differential diagnosis. We're very good at that. Mm-hmm. We do it every day, a morning report. Mm-hmm. But you get out into practice, we don't do it anymore. We recognize things, we move on. In Hardeep Singh's study that I mentioned, cases of diagnostic error, there is no differential diagnosis in the chart 80% of the time. So wouldn't that be a simple thing we could all start doing? Make a differential diagnosis in every case, especially the cases that you're really sure about, because you're just as likely to make a mistake there as anywhere. The problem with that is that you may start ordering more tests, and those have consequences too. So that's the problem we face in this business. It's a matter of finding the sweet spot. And I don't know if the computer will ever be able to do that. That's something we do really well as humans, clinicians, finding that sweet spot. Mm-hmm. What is the right number of tests that I need to do to get me to the answer? And I don't want to order too many, and I don't want to order too few. I want the right number.
Very good. Unless anybody else, maybe one last thought or question. A key issue seemed to be measurement. How do we even measure diagnostic error? How do we even define it? It's almost like you can tell if it's happened way after the fact, but a lot of times it's hard to get that feedback because we don't even know what to measure. What could we report to people that helps them?
Measurement is the weakest link right now. The measurement systems that hospitals use to monitor patient safety breakdowns are very ineffective at detecting diagnostic error, but it would not be tough at all. All we need to do is ask the patient. You were in the hospital last month, or you were in the ER last month. Did we get the diagnosis right? Mm-hmm. Patients actually know. Or you could ask doctors. Bob Trowbridge is a colleague of ours at Maine Medical Center. He's a hospitalist. And he told his hospitalist friends he was interested in diagnostic error. Tell me about the cases that you encounter. In a 6-month period, 36 validated cases of diagnostic error, none of which were picked up by the usual event monitoring systems that were in place. So it's not impossible. It's very doable.
Very good. Any last thoughts or last questions? Otherwise, thank you so much, Dr. Graber,
Thanks,
for a great
everybody.
session and great overview.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.